Good morning, everyone. Thank you for joining us today for Friday Fellows. Our speaker this morning is Dr. Jeffrey Curtis, the inaugural Harvard Ball Professor of Medicine at the University of Alabama at Birmingham Division of Clinical Immunology and Rheumatology. Dr. Curtis is the current co-director of the Pharmacoepidemiology peer group here at UAB. He holds a medical degree, a Master's of Science, and MPH. He completed a graduate program in clinical informatics at Stanford University, and he's board certified in both rheumatology and clinical informatics. In addition to co-directing peer, Dr. Curtis is the director of the lead PI of the NIH-funded R01 Verve Trial, which is investigating a herpes zoster vaccine. Excuse me. Sorry, go very long body over here. In addition, that he is also co-director and co-PI of the Arthritis Patient Powered Research Network, UAB's PCORI-funded. For those of you who are not familiar with PCORI, the Patient Centered Outcomes Research Initiative, is a partnership with UAB and a private entity known as the Global Healthy Living Foundation. Dr. Curtis is the PI along with Seth Ginsburg, and the investigation focuses on individuals with RA. Principally, and also psoriatic arthritis and spondyloarthritis. Dr. Curtis has an extensive knowledge and interest in clinical informatics and digital health, and that's going to be the topic he's going to speak with us today.
Well, thanks very much. And my intent is that this, we're not a huge group, so my intent is that this is informal. If people want to, comment, interject, heckle, raise questions, feel free to do so as we go along. So I'll apologize in advance. My perhaps main disclosure for this talk is I'm a rheumatologist. Pretty much all of my examples will come from musculoskeletal diseases, but all the principles translate well to whatever it is that you're passionate about and you study in your content area, because this is really focused on methods and tools and things like that, with the intent that it will help generalize to whatever it is that, that you're excited about. So I started life, frankly, in my fellowship in rheumatology, very interested in comparative effectiveness and safety. And pharmacoepidemiology was what I would have called myself, but a lot of people don't really know what that is, but people at least have an intuitive feel for comparative effectiveness and kind of what that is. That actually does include safety. And so it's helpful, I think, to consider what are the data sources that one might use to study comparative effectiveness of drugs or devices or other interventions, be they behavioral or procedures, etc. So there's the electronic health record. So those who are clinicians, of course, contribute data every time that you show up in clinic and you enter data in an electronic health record. At UAB, we have a system called I2B2 that basically allows you to generate not just count data, how many people have certain health conditions that might be identified by use of certain drugs or ICD-10 codes or procedure codes or inpatient stays or things like that, but you can download person-level identifiable data sets with IRB approval for your own use. So that tool has been in use for a number of years and I think has proven quite effective to really facilitate people's own research. As one example, but one among many, we are one of the co-leads for the data analytics, for one of two national data analytics centers for the American College of Rheumatology's RISE registry. So the notion is that you have an electronic health record asset that is essentially everything pretty much that happens at UAB. Let's go turn that into a registry. And so that is my specialty fields, the ACRs, that's their registry. There's no consent, just suck everything out of, everyone at UAB who is seen in rheumatology, suck every data point out of their EHR, and then do that for 1,000 doctors or 1,000 sites across the country. So that model, in fact, is used now by a lot of specialty societies. Cardiology probably had the biggest start. They have their very large clinical registry. So there's a lot of drug and device registries, but there's no patient consent. Nobody is actually putting data into some REDCap database or some electronic, case report form. It's literally everything in the EHR, and then you essentially can treat that like a cohort or a registry. So that's the notion of a EMR or EHR-based registry. With your and my tax dollars, PCORnet, funded by PCORI, that Jeff gave you the acronym just a couple minutes ago, essentially spent more than $500 million with AB to create a national comparative effectiveness infrastructure with its backbone of electronic medical record data. There's roughly 120 million-ish patients that are in that. It's not the whole country, but 120 million isn't bad. So those are three very large-scale, either local here at UAB or national with specialty or multi-specialty electronic health record data sources. As a fellow, I was very interested in studying safety of biologics like TNF therapies, adalimumab or Humira. If you watch TV, you can't avoid direct-to-consumer ads about that and a bunch of other drugs. So safety was really an increasingly hot topic, looking at both serious infections, opportunistic infections. A lot of my work studies rheumatoid and psoriatic arthritis and psoriasis, and the prevalence of that is a bit less than 1%. And looking for things like tuberculosis, which is a few per 1,000 patient years, if you're studying a disease that's that uncommon and an outcome that's that rare, you better start with a whole lot of thousands of people. And so that's where I really cut my teeth as a fellow, even on health plan claims data. So here at UAB, we have a number of different data sources. We have, the Medicare random 5% sample. So that's, just a 5% count of everybody in the country with Medicare. We have several 100% sample cuts of other targeted diseases and populations that several on campus work with. But, claims data is going to be a mile wide and it's an inch deep, but it is every drug that's filled that is billed to a pharmacy or prescription coverage. It's every ED visit, it's every hospital stay, etc. So you certainly get big numbers, even though you lack granularity. We always want biospecimens. I'll return to that in just a bit. This is not to obviate the role or the appropriateness of certain disease registries. If there's things that will never find their way into an electronic health record, they'll never be in administrative claims data from a large health plan, Blue Cross Blue Shield or Medicare or Medicaid, then there still is clearly a role for registries. And obviously, if you want to couple deep clinical data with biospecimens, then a registry may be most appropriate. But even if you had all of the electronic medical record data on planet Earth, there will be a lot of things that will never find their way into the EMR because they're in the hearts and heads and minds of patients. And so a number of years into my career, I realized even if I have lots and lots of EMR data, in fact, even if I had all of it on the whole planet, there's going to be a bunch of stuff I'm missing. So, in-office mobile technology might actually complement what will otherwise not be in the EMR data source. So there is an informatics group on campus that I'm part of that we stood up an in-office app to go get PRO data, and that's now being used in rheumatology and palliative care and the 1917 clinic and a number of different groups on campus that are interested in getting a more holistic view of how patients are doing and feeling that can be collected digitally.
Yeah. Joe, you offer to interrupt and ask questions.
Again, I'm not fussing at all. I'm delighted.
So, if I heard you correctly, what you said is anybody can access electronic health record at UAB via I2B2 as long as you have a protocol, and
yes,
search, and IRB approval, and so forth. Is that correct? So
that's correct.
And all of the funnels have access to that.
That's right.
We're moving towards a model where you can get aggregate data counts through I2B2 without this kind of research.
My question to the group, and that may be helpful to you, is anyone using I2B2 as a way to capture data in this group?
Minor way, just as a counts for a grant application, say UAB sees X number of heart failure patients and this is their basic demographics. But that's the sort of like most surface level of I2B2, but it's really useful for that one.
Anybody else?
I mean, I am, but
No, I know you are.
Does anyone have, before Dr. Curtis said I2B2, has anyone heard or gone to the website even? Okay.
if you do any local research with UAB patients, this is definitely worth investing a bit of time to look into and understand. It is the most efficient and richest local data resource. If the kind of information you want is likely to be in whole or in part already in the EMR. Yes.
Do you have to, for example, send an IRB?
So if all you want is aggregate counts, as Jeff just mentioned, probably not, because they're prepped to research, how many patients have condition X, but if ultimately what you want is a person level, potentially identifiable data set, for that you need a protocol and you'll need IRB approval. But just to say, you know, how many people have condition X based on this ICD-10 code, you don't need lots of approval for that.
So we have a couple of slides, not we, but UAB. One is to identify patients with incident gout that Ken Sack is leading. And the other one is patients with newly diagnosed uncontrolled hypertension. That is going to be part of a randomized clinical trial that Paul Mutner leads. So there are many opportunities as you get there. Thank you.
And then, because patients don't live life on this campus, you know, you might want to know, well, what's going on the 360-ish days that they're not having contact with the medical system or your research study. So that really prompted the last several years, at least for me, to be increasingly interested in mobile technology, because there's a whole lot of things that occur in people's live life that otherwise we will never know about as doctors and clinicians and providers and researchers. And so this really presents unprecedented opportunity. But if people have to continually ask questions or answer questions or fill out some survey, of course, they're going to get fatigued. So you might say, well, you know, maybe people could wear something that they don't actually have to answer any questions. And so how many of you wear an Apple Watch or a Fitbit or a Garmin or, okay, so a couple people, but, and frankly, healthcare providers tend to be more Luddites than other folks that perhaps are a bit more connected to this. But, you know, passive sensor devices, the idea that you could get a little bit of information about people, but in fact, maybe if you had mobile tech or things that people could wear, then you don't need to bother them as much. You can reduce participant burden and go grab things passively. So there's a measure called life space. Are people familiar with this? So the idea, and this is an instrument that was developed by folks here, mostly in geriatrics, Cynthia Brown and Richard Allman and others, the idea that is as you get sicker, your world contracts. So I actually watched this in both my parents and my in-laws. So, you know, as people developed different diagnoses in my own family, you know, one of my family members in my extended family, you know, got cancer, and you know, she quit traveling as much, and she quit driving as much, and then she quit driving at all, and they, you know, quit going to church, which was an hour away in San Francisco. You know, their world contracts. They go out less often, the distance they travel is less, and many here at UAB have actually shown this is a great predictor of, you know, future health and future inpatient hospitalization and costs and things like that. So there's this questionnaire, the instrument is the jargon for those who don't do that kind of research, that basically asks, you know, how far that you go out and how many times you go out and the distance, etc. But, you know, your phone knows that, and your Fitbit Versa would know that because it has GPS. So you don't have to bug people saying once a week or once a month, like fill out these 12 questions. They probably need to fill out it once or maybe one of those 12 questions, but then mostly you just go grab their geolocation and you pretty much would know the answer and not bug them. And that has been a very powerful predictor of hospital admission and mortality and healthcare costs and utilization, etc. And that's, of course, just one example we could think of where passive sensor devices might be very helpful. And of course, tracking actigraphy and mobility and sleep and all those, and energy expenditure, in some sense, that's now, you know, par for the course for what these devices can measure, even for things you can buy at Best Buy, not even research grade. And then social media, and I'll return to that just a bit with a few examples. But I think rather than think of these as isolated little data sources, in my mind, the goal is really bring all these things together. Ideally link between data sources, because every single data source here will have holes and will have flaws, but if you can plug the holes of one kind of data with a different kind of data, you can probably do a lot better. And in fact, I'll speak to that a bit as well, but there are methods that permit you to do that. So this is really all towards being able to grab real-world evidence. And just to level set expectations and definitions, real-world evidence is information on healthcare derived from lots of sources that is not the typical research enterprise, certainly not the RCT world. It can include data from electronic health record, health plan claims, registry, mobile health. Obviously, generalizability is big. Lots of papers suggesting that we only have direct evidence for maybe 15 to 20% of what we do as part of healthcare, and the diseases and the heterogeneity of patients and their comorbidities, you know, often we are left with extrapolation from high quality evidence to what we need to actually use to make decisions in the real world. There's a lot of things, though, that are not going to probably be studied in a traditional trial setting. Factors related to the health system, or distance, or social and behavioral determinants that are not often going to be in RCTs, and you obviously can't randomize somebody to some of those social determinants of health, and so that's important to study. And adherence, and low adherence, of course, is hugely important for lots and lots of outcomes, but people with low adherence generally would be excluded from a trial once that was detected. It's obviously efficient to reuse data that's already sitting around, but in fact, real-world evidence is compatible with both being able to deliver an intervention and, if needed, to randomize. So sometimes people think real-world evidence equals observational, and it often is, but that's not necessarily the case. And one of the things that helped really give a shot in the arm to real-world evidence is that in December 2016, the FDA now has both guidance and some authorization via the 21st Century Cures Act to include real-world evidence in the regulatory process. And while probably you're not going to get a drug or device approved solely on real-world evidence, I think most people are expecting a label expansion, meaning it's approved in a high-quality study in this disease indication. Maybe you could get it expanded for another indication if you brought good real-world evidence, but that doesn't have to be a multi-million-dollar RCT. Post-marketing surveillance programs that might be satisfied with real-world evidence and not a $50 or $100 million safety trial that, like 5 or 10 years ago, that question might have required. So the fact that legislation and regulatory agencies have expanded authorization to use real-world evidence, I think, has a lot of people much more enthusiastic than even they might have been. But in order to use and generate and interpret real-world evidence, we're going to need some additional approaches and tools, and one of those is pragmatic trials. So as one example of something that I've been involved in, as have many on campus, so I wanted to give you an example of the Verve Trial, which is a randomized blinded pragmatic trial of 1,000 people, or as many as needed to answer the question to hit the primary endpoint, age 50 and above, on an anti-TNF biologic that are randomized 1-to-1 to the live zoster vaccine versus placebo. So for those who don't work in autoimmunity or inflammatory diseases, this is kind of an edgy sort of thing, because Zostavax is a live virus vaccine. You are giving a weakened, attenuated version of varicella, or the chickenpox vaccine, the vaccine that causes shingles. So an anti-TNF drug, like a lot of other immunosuppressive or modulatory drugs that we might give for rheumatoid or psoriatic arthritis or sarcoidosis or Crohn's or colitis or frankly a whole host of diseases, probably suppresses your immune system to some extent. There has been a general prohibition, like a contraindication, i.e. don't do this, that you don't give live virus vaccines to people that are on biologic therapy. In this case, you're blocking tumor necrosis factor. This isn't based on high quality data. In fact, this isn't based on any data at all. This is based on, a dozen smart people a decade ago sitting around thinking it might be a bad idea. And the bad idea would be that if you give a live virus vaccine to an immunocompromised patient, you will actually give them chickenpox. You will give them varicella infection. So because of that theoretical concern, in both the prescribing information and the contraindication section for Zostavax, as well as other live virus vaccines, and all of the biologics we use in GI and derm and rheum and a bunch of other conditions, it basically says don't give people any live virus vaccine because of the safety concern. But again, it's based on no data. So because people with RA and lupus and psoriatic arthritis and a bunch of other conditions in my world are at higher risk for shingles, we said, maybe it's not warranted to withhold this vaccine that works reasonably well from the highest risk patients. Rheumatoid patients, for example, have roughly double the risk for shingles, lupus more like triple the risk. And so you've got a vaccine that works reasonably well, and yet you're telling these people don't vaccinate them because of a theoretical safety concern. So this pragmatic trial basically sought to answer the question, is this concern, is this prohibition against a live virus vaccine in biologic-treated, somewhat immunocompromised patients warranted? There's 42 days of active follow-up for safety outcomes. In other words, if you're going to have varicella infection that you give someone in the trial, it's going to happen pretty early. This is not going to take months and months to evolve. It's going to happen basically in the first 30 days, and so 42 days provides a reasonable, comfortable margin. So in other words, we could reframe the hypothesis is you're not an idiot to give a live virus vaccine to somebody on this class of biologics. That's really what we're testing. So follow-up for longer-term effectiveness is actually with a linkage to either electronic health record data and or claims data. So the idea is for 6 weeks, we really need to know if we're giving you varicella infection. But after 6 weeks, essentially you've answered the safety question, and then we just need to know how well and how long it works. And in fact, EMR data and even health plan claims data is pretty specific to identify shingles. So you might say, well, why would we keep people coming back for visit after visit after visit if you could go use pharmacy and claims and electronic health record data so that if somebody shows up in the ED or primary care docs or their specialist and have shingles, if you see an ICD-10 code for varicella and you see acyclovir or valacyclovir, the positive predictive value of that exceeds 90–95%. So you don't need to keep having study visits simply to ascertain, did they get shingles year after year after year? You could link to that data as long as you thought about it up front. We have biospecimens, we're getting PBMCs, we're looking at changes in cytokines and interferon and interleukin-2, et cetera, things that are relevant for the biology. So we haven't sacrificed this, and then we get follow-up at a year later. But we used an internet-based iPad system to help provide EConsent, because you really want things to be efficient to screen for such a trial. So we created a little video, and Jeff Foster and a number of others were very instrumental to kind of help pioneer some of the methods that we would be using. That is a 6 to 7 minute video. It's cute, it's cartoonish, that essentially describes what the study is all about. And the beauty is for somebody you're interested in providing this information to, you can hand them the tablet, an iPad, and you can walk away and you can come back 7 minutes later. But it walks through what the study is, it brings them all through the consent information, and it gives additional information about the study, not just sort of the legalese of the consent form. And I think it does a reasonable job explaining it, but it also does it in a standardized and structured way. And that's another benefit. Because for a safety trial, if the study coordinator or the investigator's in a hurry, or you have to go to the bathroom, or you're 3 patients behind, or you're really hungry, maybe you skip over 1 or 2 really important things, but this is structured. It's always the same way every time. But the bit that the IRBs loved was this. At the end of the e-consent process, and you seeing this little video and it walks you through the consent, we basically give you a quiz. We called it a knowledge review because quiz sounds scary. It's a quiz. The main reason that the study is being conducted, it's ABCD, and if you get it wrong, then we remediate you and you go back, and we can hypertext you to the section that actually had the right answer. And obviously, if you still can't get it right, then you could tell people that they don't qualify, because you want people to really understand it. But the IRBs really like this, because this is a much better standard than are the patient's initials on the bottom of every single page. This is, do they really get it? Now, of course, there's still opportunity to ask questions of the physician or the site investigator, but you can basically hand them the tablet. They go through the e-consent. They go through the more formal consent document. It's like a Kindle reader. If you've used that, you can touch and hold the word, it defines it, etc. But so most of this can be done without a study coordinator in the room. The idea is make it really efficient for the site PI, make it really efficient for the project coordinator who doesn't have to explain this. Because mostly when you explain a research study, you sort of go into your spiel, and it is the same thing for about the first 80 or 90% of it every time. The value in talking to the human is to ask questions and just confirm that this is a good study for that patient individually. But most of the, what is this whole thing about, that's pretty boilerplate. And so the idea is use tech to make this very efficient. And then at the end, patients sign consent electronically. So signing consent with your signature electronically actually has some different legal requirements as providing an electronic signature. I've learned really valuable things like that. But if you sign signatures like this digitally, that's not the same as like a DocuSign or Adobe, electronic signature. So there are a few nuances, but this is not rocket science to figure out. That same signature, though, can be used and is used for the medical record release form, as well as for linkage. The consent form entails that we have your permission to link you to any EMR or health plan claims data for the future. Because if the primary safety question that needs to be answered is answered in 6 weeks, and it is in this pragmatic trial, then why should we make a trial that's any longer than 6 weeks? So in fact, that's the bit that patients really liked. That's the bit that sites liked. Mrs. Smith, you are done with the study in 6 weeks, and there are exactly 2 and only 2 visits. Because again, if that's what you need and all you need to answer the question, then don't, make it more complicated than that. And so there's exactly 2 visits. That saves money and it saves participant burden, but then it allows us to link down the road. And then we have a centralized call center that goes and gets medical records for serious adverse event ascertainment. And we actually check up on people at 6 months and a year. And for biospecimens, we partnered with Quest Labs, where we basically send you a lab kit that you can go to the nearest Quest Labs. We direct you based on your zip code to go get that biospecimen and then mail back to us. And that's how we build our biorepository after 6 weeks to know about annual changes in some of the PBMC-derived lab assays.
Yeah. This is fascinating. So thank you. Some of the people here, some of the surgeons are working with low literacy material, for surgery. The question for you is, patients who receive anti-TNF, so your study population, do we have a sense of what is the usual literacy level? Is that similar to other?
It's going to be what it is in other healthcare settings. I mean, mean age of people that are in these is 40s, 50s, 60s, but I would assume that the literacy level is as low as it always would be for any healthcare intervention.
I would, go ahead.
I was gonna say, so like my primary care office, they've started doing iPads for check-ins and things like that. But the people over, so you're only looking at people over 50, right? So
for this trial, it's 50 and over, that's correct.
Did you have issues finding like the older patients having issues just using an iPad or using technology?
We really didn't. 2 things that we've learned about that, and I'll come back to that when I speak in just a couple minutes about getting that in routine settings. One point of reticence is that people are afraid of it. It's not that they can't do it, it's that it's unfamiliar and therefore uncomfortable. So once you spend a couple minutes with them and just demystify the process, usually that overcomes the major hurdle. It's not that they can't do it, it's that they won't do it because they're afraid of it. The other thing we learned is that acrylic fake fingernails basically don't register on a touch screen, so we had to add a stylus, and I wouldn't have known that because that's just not anything I would have thought about. But if you own a smartphone, this is nothing, but for older folks who don't, yeah, it was relevant, and there's a handful of people, it's single-digit percentages that want somebody to just sit there and press. I mean, again, you want something to be grandma-proof. I mean, that's my litmus test, that if grandma can figure it out and grandma can do it, then great. For this, it's a trial. So the study coordinator is basically setting it up, entering a participant ID or sort of a screening ID, hands it to the patient. I mean, it's not much more complicated than hitting a next little icon. So this is not something that they're really having to manipulate much on their own except to go to the next screen. So the beauty of having this signature collected electronically, there's no paper. There's no case report forms that somebody then has to take what the patient said, type them into some database or electronic data capture system or REDCap. There's no paper that the patient has to fill out. And we generate a medical record release form on the fly. So we can use the same signature and we can basically create an on-demand HIPAA-compliant authorization and medical record release form. Originally, our IRB said, well, you need a signature for consent for the study, consent for the biospecimen repository, consent for the HIPAA authorization, and consent for the medical record release form. I said, really? I'm going to have to collect 4 signatures. They said, yep, because that's how we do it. I said, I understand that's how you do it typically, but why are we doing it that way? So as long as patients really are understanding what they're agreeing to, why would we insult them by signing their name 4 times? How is signing your name 4 times any more likely to make sure that the patient gets it? Why don't we just explain it in plain language? I'm okay with saying, hey, by checking here or clicking yes, you understand that ... And they said, yeah, okay, that makes sense. You don't have to sign 4 times. You don't even have to sign twice. We'll let you reuse this one signature, but, pop up something that says, please confirm that So I had a number of IRB conversations, as I commonly do, that start with, This will be different than you're used to thinking about, but keep an open mind, and then we'll start the discussion. So this may make me not very loved by some folks because it's different, it's new. One of my 33 sites said, oh, we can't accept EConsent, we just don't do that. It was Ohio State, which actually is quite top-notch in terms of biomedical informatics, and I said, you know, the FDA actually has a guidance document that we followed pretty carefully around EConsent. After about a year and a half, they changed their mind, but new things are sometimes trickier, and so I'm certainly acknowledging that.
Do you have issues with the retrieving medical records with the electronic signature?
We really haven't much, because again, the medical record release form looks like you otherwise would. You're thinking like because it's not a wet ink one, or I mean, if you photocopied the wet ink one, it's still going to look photocopied.
So we have problems with the wedding, with getting the photocopy. We have a lot of hospitals come back to us and say, we want you to sign art.
Yeah, so if that's the problem, yeah, so it's not that it's electronic, it's that it's not your, facility-specific medical record release form, and yeah, this obviously doesn't get around that issue. But this would let us we would still reserve the right to contact you if we needed a facility-specific one, if they want to accept that. So you're right, that doesn't, if you need it from Hospital X in Dallas, then, you're going to have to go get that form specifically signed. But then you might say, well, this is what I think of as a all-comers trial. It's a pragmatic trial. The notion is if the safety question is, I just want to go give people this live virus vaccine, then who should be in that trial? Well, it's anyone who you might want to vaccinate. Well, who should be vaccinated? Well, pretty much everybody over 50 on a TNF inhibitor. So that actually is the trial's inclusion criteria. You're age 50 and over, you're on one of 5 TNF drugs, and you're not dying. That's essentially it. So it's an all-comers trial. So in fact, much like we were talking about a few minutes ago, you might say, well, I could find those people in my electronic medical record. The medical assistant who checks people in, he or she would know if the patient's 50 or over, and they do medication reconciliation. That's sort of a quality metric. So if your main criteria are age and you're on one of these 5 drugs, like why would we wait for doctors to refer people to the study? And in fact, at least at some sites, including here, we didn't have to do that. So if the inclusion criteria for your pragmatic trial are not complicated, this may be very easy. And here, you could use the electronic data warehouse, and particularly I2B2. There's another tool called Trinetics that's used, and there's a few others that are out there. But the idea is go use an automated tool to go search for all these patients. So we searched I2B2. There were 1,470 patients receiving TNF therapy. Again, indication is unnecessary. We're not restricting to people with certain diagnoses. It's just you're on one of these 5 drugs for any reason. And then we gave that list to a study coordinator who contacted every single person, either by phone, in person, or on the patient portal to go find people. And no physician ever had to refer any patient to the trial. The study coordinator started, and he knew every single patient on the entire UAB medical campus who was ever on any of these drugs. And then one of the things that I asked to be added to the I2B2 and the data warehouse is their upcoming appointment dates, i.e. scheduling. When are they next going to set foot on the UAB campus anywhere and have contact, so that if he couldn't get a hold of them, that he could actually go show up in the derm or the GI or the infusion center clinic and actually tell them about the study. So we contacted literally 100% of 1,470 people with a part-time FTE study coordinator to do that. And again, no clinician ever had to refer somebody to the study. And the sites that did the best in this trial had a way to search their own data warehouse via one of these tools or some similar tool that the EHR vendor or the health system provides. And so that made things far more efficient than the usual process. You stick somebody in clinic who, tries to screen people or manually looks at medical records one at a time to try to find the thing that's your inclusion criteria. Being able to search data made this very, very efficient. To invest in such tools, though, really makes the most sense if you have a data warehouse or some sort of large-scale physician network. But again, you're part of one here, and those are becoming increasingly common. So thinking now about what are the kinds of data that you might want either to screen for your trial or frankly that you just want in your observational study. So I'm going to go give you a bunch of examples on the left. This is what I'll think of as sort of the old way to go find stuff. You know, you could do functional testing, you know, a 20-meter or a 6-minute walk test. You know, you could do personal interviews about social networks. There's a bunch of ways you could get socioeconomic status with census and geography based. You can read, and I'm not going to read them all to you, but everything on the left, those might be the kinds of data that you want, and maybe some examples of where historically you might go find it. However, there are other sorts of data of pretty much that same kind that maybe could be more accessible. So I'm going to go give you those same types of data, but to give you a different sense of where you could go find it. So for example, for diet history and for what people are eating, you know, one of the IBD groups that I work with, essentially people are crowdsourcing restaurant menus and taking pictures of things rather than very complicated, you know, food frequency questionnaires. You know, when I want to know what the average home price of the neighborhood is, I look on Zillow. And if you know what people's, you know, zip codes are, you can go find lots of other sources of data that maybe is a bit non-traditional, but is out there potentially for the taking, so that some of the things on the left, you don't have to rely quite as heavily on if you can have some of the things on the right. So the point is there's a lot of new places that you could go get data if you can only access that, and I'll speak to that in just a minute. So all of this is really in pursuit of big data. And by way of reminder, you know, big data is typically considered as a data set so large and complex that traditional methods and statistical and analytic tools often are inadequate to house it and analyze it. It's typically defined by the 3 or more V's. So velocity, the data is coming at you very quickly. Volume, there's a lot of it. And variety, that it's different kinds of data. It's not just more of the same thing. There's at least 1 or 2 other V's. I think one of those V's for me is value. You want to bring value particularly to the person that you're asking to provide the data, because if they won't share with you, then you've got nothing. So in my mind, you need to deliver value to all of the stakeholders that are part of this research process. There's, you know, a few nuances, big data in the small. So for one patient, you could essentially capture lots and lots of different health domains, and small data is kind of what we are used to thinking about. Administrative data might be initially perceived to be big data simply because it's big. So that at least gives you the volume. Medicare is a good example. You know, it's all the claims data for everybody with Medicare, which covers 95-ish% of people age 65 and above. You know, commercial health plans, United Healthcare, and their data arm Optum or Aetna or Blue Cross Blue Shield. We're basically a single payer state almost here in this state. Blue Cross has 80 or 85% of the commercial market. They dominate this state more than any other commercial insurer dominates any other US state. So if you have Medicare, Medicaid, and Blue Cross data in the state of Alabama, you have almost everybody in our entire state. Of course, it's claims, so it's lacking in phenotypic detail. You have a mile wide in terms of breadth, but it's only an inch deep. You have procedure codes, you have ICD-9 and 10 diagnosis codes, but you know, you typically don't have disease severity and things like that. ICD-9 to 10 transition gave us a lot more granularity. We had about 14 or 15,000 ICD-9 codes. When we had ICD-10, that went to close to 70,000 codes. So as a researcher, I thought, great, we're going to have so much more richness and detail. And as a clinician who would actually have to enter those codes when he saw patients, I said, oh, shoot, we have 4 times as many codes that we have to look up. Some of the codes, though, out of those 68 or so thousand ICD-10 codes, are not particularly useful. So this is one of my favorite examples. So if you had a patient that was sucked into a jet engine, you would use ICD-10 code V97.33, and if they had the misfortune that this was a subsequent episode of getting sucked into a jet engine, you would use the suffix XD. So this is a real code. I have never seen this or used this code my own self. So the point is those 68,000 codes are not all equally useful. A couple of my other favorites, bitten by a cow, you know, injured in a killer whale attack. I mean, not all of these are necessarily useful, but this isn't really what I mean by big data. I've given you some examples, mostly just look at the column headers, since some of the subsequent rows are examples, a few of which are specific to my own field. So there's traditional registries, there's EHR-based registries where you could derive a cohort, there's patient registries, and then there's health plan claims, just as a few examples where you could go get big data. But again, you might want to link across data sources. One of the things, though, that's very helpful is if you could normalize all of the data or standardize it. So the idea is if you're working with our EHR data or this claims database, and then you had a different claims database like Medicare, for example, or Market Scan, which is about 30 million patients mostly enrolled in commercial insurance, you might say, well, I'd like to actually analyze multiple EMR data sets that I have access to and multiple claims data sets. So rather than have to write a SAS or Stata or R program, with this set of variable names and then write a whole nother program with another set of variable names, if you went to some upfront trouble and you standardized or normalized all of the data to one common data model, one set of variable names, if it's sex, is it sex or is it gender? Is it male or female? Is it M and F? Is it 1 and 0? Is it yes and no or Y and N? I mean, you could spend endless amounts of time arguing about that just to harmonize two data sets, and even so you'd have only have your homegrown data model. But there are 3 or 4 data standards of common data models where somebody has gone to the trouble to have a specification that would allow you to normalize those data sets. So when we do analyses where I want older person claims data like for Medicare, and then younger people in Market Scan, which again 25 or 30 million people, I only want to write one set of SAS code. So we have standardized the Medicare and the Market Scan data against this same common data model, so we can write one and only one SAS program, making that much more efficient. So there's 3 or 4 national standards. The one from ProCornet is the one that I use most commonly. There's a couple more. The FDA Sentinel system, their signal detection system, uses one, and then there's another one called OMOP that some on campus use. But the notion is that rather than have to create a new data dictionary for every kind of data and every data set, if you're analyzing more than one, then this lends a huge amount of efficiency. And it also insulates people from having to mess with the nuances of specific variables. So Market Scan data isn't that complicated, and if anyone's interested in claims data for their own projects, certainly talk to me because that's available on campus. We license that for the whole campus. But those variables are somewhat different than the way Medicare would represent the same thing. So in fact, if you want to work with the normalized data and not mess with the exact file names and variable names, you can work against just with the normalized data, which makes you a lot more efficient if you want to analyze more than one data set. So where this is potentially going, though, is to help design a learning healthcare environment. So that's a big buzzword now. So the notion is you design a program of care or a care pathway or an intervention, you would implement that, you would evaluate whether your strategy is working. So, if we have, nurses and medical staff in clinics systematically trying to identify people who are overdue for vaccination, maybe you introduce some friendly competition to improve vaccination rates, you're designing a care intervention. You then have something to measure. You have data to know, hey, are people actually getting vaccinated? You probably want to task staff with that and not doctors, because doctors are probably the weakest link for something like that. And then you evaluate whether your intervention's working, and then you tweak the things that aren't working so well, and you continue the things that are, and then you can tell other people, you can disseminate, but then you iterate on it. So this is sort of a rapid cycle process improvement, or plan, do, study, act, if people are familiar with that. So the notion that every time the clinician shows up in clinic, he or she is generating potentially research-grade data that can improve outcomes, but that you use data and analytics on it to understand and to implement evidence implementation or interventions, implementation science type things to improve quality of care. And unlike saying, I'm going to design my intervention, I'm going to roll out the whole thing, and then at the end, I'm going to figure out if it worked or not, this can be a small series of iterative cycles to implement something and to improve outcomes and to track quality. So this is the notion of a learning healthcare environment, that we're going to actually learn from our mistakes. We're going to learn from the things that we do well. We're going to share best practices of what worked with others and what didn't work. And then we're going to continually make it better. And healthcare systems and healthcare entities that are good at this, that are efficient in this, are able to improve quality of care much more quickly and effectively than those that can't harness their own data and figure out what's working and what's in need of being changed. So this, when I was in training in internal medicine, evidence-based practice was all the rage. And people then, after a few years, realized, wait, there's a whole lot of stuff that we have no evidence for that we still have to practice medicine. And so now we flip that concept kind of on its head, that it's now practice-based evidence. We're generating evidence as we practice that can help make us smarter. So that then makes me want to think through, do we need to randomize? So, high-quality interventions and trials will often benefit from randomization, but I think it's worth spending at least, just a minute or two thinking through, why do we need to randomize? So what are the benefits of randomization? This is the interactive part of the talk.
Kind of equalizing things, all things being equal.
Right, so you're equalizing things, and what problem, frankly, does that solve?
Bias.
Right, so where's the bias come from? Like, why is there bias? Okay, so explain what that is. Yes, but why is there selection bias?
Prevents you from picking people who you know would do well with an intervention and kind of floating one side.
Okay, sure. So why would they do well with one intervention, or sort of what's underneath that? So when a provider is making a decision about how to treat, Mrs. Smith, and, she can choose A or B, what's underneath that decision that everyone is kind of worried about the possibility of bias?
It could be compliance. It could be her stage of disease, for example, that she was likely to benefit.
That's right. And were you?
So you want your trial to have a positive result.
But
You're going to,
right. So what is it though that will get you that positive result? Like, what's happening to create bias that you're worried that you've sort of artificially created that, but it's not real?
Cheating, dishonesty, stacking the deck.
Well, most doctors are probably reasonably ethical. In the treatment decision about whether, this person gets this or that, like, what's underneath that?
Buying what's best for the patient, or what you think is best for the patient.
Right, and what is that based on?
Your own personal, experience, training,
And what else?
Interaction
Interaction with what?
with the patient.
Right, so what is it about the patient that would it be important?
History.
their own sort of knowledge and perceived competency to do things. Maybe thinking that one patient is going to be too frail to do something that another patient would do.
Exactly, and you're all right, but that's really the heart of what I was after. So the notion that healthcare interventions are not random, or hopefully they're not random. Like, doctors are not stupid. They're going to give their best estimation of compliance and adherence and frailty and comorbidities and disease severity and all the things that would go into that. So to paraphrase, the treatment decision about whether the patient gets X or Y or Z is predicated on this patient's characteristics. And so, you have channeling. People likely to do well or not well are going to be more likely to get this therapy or that therapy based on patient's characteristics. So if the patient's characteristics and the doctor's judgment of those characteristics would make it more or less likely that you get this versus that, that's really where this bias is coming from. So if I restate it, if the variability in who gets what is due to the patient's characteristics, you're probably going to benefit from randomization. But there is, in fact, a number of circumstances where it is not the patient's characteristics that determine what treatment that you get. So if patient's characteristics are the main source of variability, yeah, if you can, it's going to be better to randomize. But there's a whole lot of circumstances where doctors don't really know what to do. And so then if that source of variability is, here's what I think, but, I don't have a whole lot of evidence. This is my opinion, and my opinion is sort of as equally valid as the next guy or gal's opinion, and none of us really know what to do, then that source of variability is actually good, because then it's not the patient so much as the doctor and his or her judgments and impressions. Now, the patient still probably will have their characteristics will have probably some influence, unless we literally know nothing. But if it's mostly preference-based, or if there are influences that literally have nothing to do with the patient, then that's a good source of variability for observational studies. So for example, purely hypothetical, not necessarily grounded in reality, but if the drug rep is very attractive and charismatic and, you know, buys the doctor lunch, and that's what determines whether he or she prescribes, you know, this, you know, NSAID of the new COX-2 NSAIDs, and they have very aggressive, very charismatic and attractive drug reps that blanket the nation, and you're more likely to get a COXIB, that probably doesn't have a whole lot of influence with whether Mrs. Smith has, you know, risk for heart disease. And so under those circumstances, you know, it's the aggressiveness of the drug rep and that relationship, not the patient's characteristics about whether they got rofecoxib, Vioxx, or Bextra, et cetera. So that's where the determination of which NSAID you get may have very little to do with the individual patient's characteristics. At the beginning it did, but as time went on, who got a COX-2 NSAID versus a traditional NSAID had a whole lot more to do with marketing efforts than patient's characteristics. If there's physician practice characteristics, that could be important. So I live in a world where we give very expensive infusion biologics. If the doctor owns the infusion center, if there is a financial motivation to give this patient an infusion drug rather than an injection drug, the person in the community who bills for those infusions will make money on infusion drugs. He or she will not make money on the same class of drugs with the same indication if the patient picks them up at the pharmacy. So again, the motivation of whether I give you X or Y probably is in part influenced by whether I financially benefit or not. Whether you think that's right or wrong, frankly, doesn't matter. Whether you think that's unethical or ethical, you know, is a different conversation over a cup of coffee or a glass of wine. But if that's the reality, if there's financial motivation that have nothing to do with those patients' characteristics, then probably you don't have nearly as much concern for bias. And there's a number of circumstances. If the cardiologist, you know, owns the infusion suite or the cath lab, et cetera, you're more likely to get that procedure. So that's why some people have used some of those things as instrumental variables. You know, the density of cardiologists or cardiac surgeons has a fair amount to do with whether you get, you know, a cath or a cabbage, et cetera. So that's where some of those notions come from. It's where the likelihood you get the procedure or the treatment that is not very determined as much by your own patient characteristics, but more by availability or these external influences. I use very expensive drugs that typically cost $3,000 to $5,000 a month. I don't pick what drug I can use first line. Blue Cross Blue Shield of Alabama tells me if I want a TNF, I have 5 choices in theory. The reality is everybody in my whole practice who with Blue Cross Blue Shield gets adalimumab. That is the only one I'm permitted to start with. But if I lived in California where I'm from, that would not be the first line. There's 2 different TNFs. So if I compared Blue Cross Blue Shield of Alabama's RA patients to you know, the Blue Cross or the commercial health plan in California, where everyone has to start with another drug because they cut a deal with the drug manufacturer, that's not biased. As long as my patient practice is relatively comparable to the group I'm comparing with, again, the decision is made independent of the patient's characteristics. Everybody gets A versus B based simply on what's on formulary and the price and the contracting that happened that had nothing to do with me. So sometimes you can take advantage of a natural experiment like I've just said. You know, this health plan, this Blue Cross plan has first-line therapy with X, but a different one has a different first-line therapy, mostly similar indications. You may not need to randomize. Even if you can't take advantage of natural experiments, there might still be standardized care pathways or protocols. So some of the people in my field have sort of said, you know, randomizing may not be acceptable to docs and patients, but they sort of did a survey using healthcare data of what do people actually do, and essentially created consensus treatment pathways. The idea is that for this problem, for this kind of patient in this setting, all the rheumatologists in the country in pediatric rheumatology basically did one of 3 things. They kind of sort of did it different, and so they basically created a consensus treatment pathway. The notion that if you do this kind of a thing, we're going to create a protocol so that everybody does it this way. And because there's mostly equipoise in which of those 3 things that might happen to patients, you essentially can now compare the protocolized pathway that they've tried to rein in some of the heterogeneity that frankly wasn't grounded in anything. And so that's sometimes how they've gotten around of sort of just studying things in a purely observational way. They've essentially standardized the approach to where they realized pretty much all patients are following one of these three things, but there's a lot of variance. Let's curb in the variance. Let's curb in the heterogeneity due to physicians doing this, that, or the other as they tapered steroids. And essentially they got their own community to agree that, like, if you're going to do this, this, or this, can you just do it this way, and pretty much got buy-in. And that's how pediatric rheumatology compares a lot of their interventions, even though they're not randomizing. And of course, we know you can't run a trial to answer lots of every question. So I've alluded to a bit on data collection and case report form based. You know, you've got a case report form, you design it ahead of time, it's very clean, and it's manually inputted. It's expensive, you're going to pay somebody to do that. You can have an EHR based registry. That's the notion, just suck all of it out of your EHR and then populate that as a case report form. There's some nuances though about how you might use that data. But one of them is, frankly, that it's much messier because you have to sift through everything. So a lot of what I do and what people like who do what I do spend a great deal of time on is basically data janitor work. I mean, the world looks really cool like the Matrix, but frankly, somebody is doing about 70 or 80% of the upfront work to make it clean and usable. So the fun part is at the very end. That's the tip of the iceberg, and that is not the hard, down in the weeds, like bore you to tears data cleaning that anyone who does this sort of thing has to spend a great deal of time on, that people who don't do this work absolutely underappreciate and undervalue and don't know why it's taking so long. But, you know, garbage in, garbage out. So this is really to help ground you to say, you know, yes, you can use your EMR data, but that doesn't solve every problem, particularly, and you're going to make some serious investments in doing data cleaning. The questions that you can answer with traditional registries or EHR-based registries sometimes can be a little bit different, but you know, the ability to improve care and to detect changes, you know, are probably much quicker if you're able to go get everybody out of the EHR, because again, you're not putting observations in by hand manually. You might also say, well, you know, this is great to have lots and lots of data, but do we really need, you know, more data, and why? And my favorite quote is really from Google's director of research, Peter Norvig. Google themselves say, you know, we don't really have better algorithms, they just have lots and lots of data. So who remembers the Yahoo search engine? A couple of you. So remember that more or less Yahoo basically had a team of humans that would curate what are the important websites in the world. And at the time, there were only a few thousand. So they would essentially have ranking of websites for the few thousand, you know, websites that existed on the planet that humans would manually rank and curate. And of course, then things exploded and nobody could keep up with that. And nobody uses the Yahoo search engine anymore. And Google more or less figured out, wait, why do we don't have to have humans do that. Let's just figure out how many links point to a web page, and the ones that have the most links pointing to them probably are the most important. Let's just go do that in an automated way, and now no human has to touch that. So the notion that if you have lots and lots of data, you may not need very fancy algorithms, you may just need lots and lots of data. And that's where Netflix gets the, you know, people who like this movie, like that movie. Nobody's figuring this stuff out by hand. They just have, you know, millions and millions of observations that, like, if you picked this and you rated it this way, then when you saw this movie, you also rated it high. So let's go find somebody like you. So again, nobody's doing any of this hand curation by and large. But for some of the things that you and I might care about, we're going to need to link data that exists in the wild. And to do that, your life is going to be a whole lot easier if patients will provide consent to give up personal identifying information for linkage. So if you could get patients to agree to give you their Fitbit or Apple Watch data, or, you know, share their electronic health records, etc., you know, you're going to be able to harness these in a whole lot more effective way. So this was experienced from a large RA registry called Corona that's in my field. These people all have rheumatoid arthritis. So we were interested to basically expand the capacity to do email, internet surveys, mobile tech, passive data sources, but we were going to reconsent everybody. And that's kind of a big deal, and it was hugely expensive and took a couple years. Overall, in the first 4,800 patients, 17% of patients said, no, I don't want you to ever know who I am. The registry is de-identified. It was like that when I joined, and I want it to stay that way. So there was a 17% refusal rate where people said, I'm not going to give you my name and my address and age and full date of birth so that the research team, which in this case would include us and people here at UAB and at UMass, I won't let you do that. And I thought, oh, 17% refusal, it's not that bad. But then I said, let's break it out by site. How much variability is there by site? So if you break it out by site, every little tick mark is a distinct site, and the x-axis is the number of patients at that site. So further to the right, those are sites that have a whole lot of arthritis patients, and the y-axis is the proportion of people refusing. So you see that at this site, for example, they've got, I don't know, 80 or so patients, and 100% of people refuse. But then where there's no tick mark, you know, this site has 100 and something patients, nobody refuses. So what that tells you is that the site has a huge influence on whether people say yes to consent to link data or not. Patients are not that different. They are, you know, it is not that people who live in New Jersey are freaked out by privacy, but people who live in Georgia, you know, could care less. I mean, people just aren't that different. So this has a huge amount to do with what the site and what the site PI and what the study coordinator actually told people about why the linkage is needed. So when the ReConsent form was originally designed, the use case, like why do we need this, is that if you die, we will be able to submit your information to the National Death Index and track down your next of kin and figure out why you died. Would you sign that? Like, that's incredibly depressing. Who wants to sign that? I mean, most folks don't even want to think about that. So I said, this is a terrible use case. Like, we don't need to be hiding anything, but if that is your front and center and frankly your only reason why people would sign consent, I think your refusal rate is going to be atrocious. So I said, we need to actually have a much broader use case that people actually might be interested in this because you're going to give them some value. You know, you could pay them, not to pay them to consent, but to say, you know, we'll invite you to compensated research studies. Right now, this registry, everything was uncompensated. But, you know, if you fill out a survey and we paid you $20, some people might want to do that. You know, if we gave you some digital tools on your smartphone or we sent you a Fitbit to be part of the study, some people might say yes. So we greatly expanded the use cases, and that's what resulted in the 17%. It probably would have been a whole lot higher refusal if, in fact, it was only this NDI death index linkage use case. So the point is that if you're asking for people's private information and to link data, give them a good reason to say yes. Paying them is not a good enough reason, and certainly tracking down their next of kin if they die, if that's the only reason, your refusal rate is probably going to be a lot worse than if you give them other reasons why you can actually bring value to their data. Yeah.
But don't you think that can use a sort of selection bias to, I don't know, pay them for giving their data or?
So that's very important. So are the people that would say yes if you pay them for their data, like, isn't that a different kind of person who would say yes? You're absolutely correct. Don't do that. Like, that's a bad idea, probably under all circumstances. Do not buy data from patients. When we compensate people, it is absolutely not under the market or business norms of buying your data, because the mentality is like when you would get paid to donate body fluids. For many people, that just sounds icky and feels a little bit tawdry. You know, I personally will go donate blood to the Red Cross, but I would not sell my blood or any other body fluid to anybody because, again, that feels icky. So if you can rely on sort of social norms and values to donate due to altruism, I'm helping somebody, I'm doing something for the good of the community. That might be just for researchers, that might be for the good of a patient community. If you're firmly in there, I don't mind if somebody says thank you, but you absolutely should not say I am buying your data, because otherwise it invokes all those concerns that you've just alluded to. So a thank you is not the same thing as buying your data. If you want to link, and I know that the time's getting a little bit short, so I'm just going to give you an overview. You could exchange personal identifying information in a secure fashion. You could, you know, send whoever it is, or have people send you, you know, name and address and social security number or health ID or etc. I mean, if you can do that with consent, super, do that. But a lot of people aren't going to allow you to do that. You could exchange personal identifying information through a so-called honest broker. You know, data holder A and data holder B, they don't want to share the patient's information, but they're going to each send it to a third-party company that doesn't have any of the health information. All they know is enough to link. That's the idea of an honest broker, and we've served as honest brokers for these sorts of linkages where the database isn't held by that honest broker, only the personal identifying information needed to link, but it provides an additional layer of security. You can do deterministic, which is sort of rules-based or probabilistic linkage. And so we've linked a number of data sources like that. There's a large cohort some of you work with called Regards, where we linked 17,000 of those patients in the Regards cohort to Medicare data. And so we've used both deterministic and probabilistic approaches to do things like that and other linkages. You could also exchange proxies for personal identifying information. So the notion is I am never going to send you or anybody patient's information. But I could say, let's decide on a vector of identifiers. Like, what is the information that I need to link on? And it better not be SSN, because nobody wants to give you their social security number. So let's just assume that it's name and sex and date of birth. You can then apply a one-way collision-resistant hash function. Sort of think of the Enigma in World War II. And then that essentially will create a gobbledygook string. You could introduce a phrase or an additional word so that somebody just doesn't go through, a series of boy names and dates of birth and sex, because there is a finite number of combinations, and you could just go through a dictionary of men's and women's names by birth cohort year about what was popular, and you're going to get a few hits just randomly. So that's the idea of salting. So the beauty then is that if you apply this hash function, you get this very, very long string that means nothing. You could never get back to the patient's ID, but you can exchange that. And so we've actually linked that patient registry I'm going to talk about in just a minute to HealthCore data, where HealthCore is not going to send me everybody's names who have rheumatoid arthritis, and I don't want to go send them thousands and thousands of people's names, sex, and date of birth, but you can exchange this hashed function, sort of this cryptography function that you can't go backwards, and that was acceptable. And then we just looked to see which combinations of identifiers, the first and last name, the first two letters, date of birth, with or without middle initial. We actually use physician's NPI. That's not personal identifying information. If you use the first two letters of last and first name, date of birth, sex, middle initial, and like who their doctor is, in this case, their rheumatologist, the specificity of that is 99.84%. And, the collisions, we had 4,600 collisions out of 3 million patient identifiers, but, the specificity is very high. So this approach that you actually don't have to exchange PII, I think may be quite helpful if you need to link across data sources, but nobody is willing to share much of anything. Yeah.
By collisions, do you mean duplicates? Like duplicate functions?
Duplicates where, as luck would have it, there's a set of twins. They're identical twins and they have the same date of birth and they're both seen in the same health system, yes. So if you want to link data, obviously make sure you need to. There's a number of use cases you could think, well, do I need to do that? And if you have a question that a single data source cannot answer, then linking may be very helpful. So people have put the Regards cohort, where Regards is mainly stroke and MI, and there's some ancillary studies around fractures and chronic kidney disease and a bunch of other things. But, it wasn't set up to study gout, for example. But, if you link to Medicare data, you have every gout diagnosis, you have gout drugs, etc. So linkage may be helpful in that regard. We were interested to link a traditional registry to Medicare claims data to answer the question, what does it cost and what is the safety profile of people whose rheumatoid arthritis is not in remission? So for that, and the details aren't super important, but I just want to give you the idea. We needed disease activity data from the traditional registry, but we need costs and all-cause hospitalization and ED visits from the health plan claims data. The registry doesn't by itself collect that. And so you have a question, the disease activity is necessary from the registry, but all the other outcomes are in health plan claims data. You can't answer that with either data source by itself. And the methods are not that important, but basically we showed that it's always better to be in remission than high disease activity. We created these comorbidity clusters with some principal components analysis and some clustering methods. But the y-axis is rate of all-cause hospitalization, and I could show you costs, which has a similar shape. So the idea is that you have questions that you need more than one data source to answer. And then the last kind of data I want to talk about just in the remaining few minutes is patient data. And at least to a clinician audience, I will often start a conversation to say, do you even want data from patients? And what kind of data do you want? And frankly, what you don't want? Because I think it surprised me a little bit, like this was not a resounding yes. Like a lot of clinicians sort of give me this deep sigh or pause, well, I'm not sure if I want my patient's data. Like, if it makes me go home a half an hour or more or later after I would otherwise leave the office or waste a bunch of my staff time, no, I don't want patient data between visits. So what that really says is, well, how do we collect it and make use of it and interpret it efficiently? Well, if you're going to use digital technology, you might say, well, do people even have those resources? So I wrote a number of grants several years ago where I basically got dinged, and most of the grants didn't get funded because they said, well, this is really neat for, you know, younger, rich, white, college-educated people because that's who owned smartphones. And frankly, that didn't really resonate with my experience because my Medicaid patients have smartphones and iPhones, etc. I mean, that's, you know, smartphones like the new Cadillac. Like everybody owned a Cadillac, even in lower income settings in many places in the country. You know, you can go buy a car if you have some money, even if you can't move out of your neighborhood, because that's kind of a bigger deal. But in short, there's really not much of a digital divide by race or ethnicity or by education so much anymore. There definitely is by age. So I'm showing you the uptake of internet use, smartphone use, and social media by age. So if you were studying osteoarthritis or osteoporosis, the penetration in the 65 and older folks is definitely going to be lower. But if I showed you this by race, ethnicity, or SES, it doesn't really vary all that much. It's mostly only by age. So if you're thinking of an intervention that will rely on tech, it's mostly only age that I think you have to be a little bit worried about. The 2017 numbers are slightly better than this, but the pattern is still the same. I'm gonna skip this here. We've done work, because a lot of stuff will not be in the electronic health record, to create mobile tech to go grab PROs. So the notion is that if I want to know how my patient is doing, you know, I could go ask them, how are you sleeping? How's your mood been? Or I could have them, you know, fill things out on a tablet in the waiting room. I may or may not want to do a joint exam. You can give it to every patient. We created an app to do this that's kind of rheumatology specific. There's some on campus that do the same sort of thing. And the rheumatology one is available for free on iTunes. But the notion is if any of these domains or whatever instrument or survey you want in your own research, like if patients could fill that out with or without a bit of doctor information, just how do you make that incredibly easy, and how could you make that on mobile? This is what the interface looks like. It's very touchscreen. It's not hard to use. To somebody's earlier question, I mean, you press the button and pretty much move on. So this is a pretty simple user interface. We did a time motion study. We did a usability study just to make sure that this was as easy as we hoped. This is the study that I learned that fake fingernails do not trigger a touch screen. But it's pretty simple stuff. But the thing that I love as a clinician is this. Before I walk in the room, I already know that, you know, Mrs. Smith's right elbow really hurts, and, you know, her hand and her shoulder hurts. I already know, you know, what her pain score is, the fact that her sleep is good, but she's really depressed, and, you know, this is her anxiety and fatigue score. So the first 5 minutes of my encounter are not, hi, how are you? How are you sleeping? How's your mood been? What hurts? You know, what's your pain level like? Are you in the middle of a flare? Like, the first 5 to 7 minutes is not primary data gathering in the clinic visit. But then the beauty is I now have this available for research purposes and secondary use, even though my primary use is to take better care of Mrs. Smith. And then I can trend things longitudinally over time, et cetera. And this is one of the ways that bringing value to patients, I think, is helpful. If this is all one-way information transfer, Mrs. Smith has to fill out all these questionnaires. She never knows what you're doing with the data. Her doctor never uses it. You know, the iPad gets left on the counter and no one ever reacts to it. She's not going to be very enthusiastic about filling out, you know, your registry form or your data collection forms next visit, because you've not brought her any value. But if her doctor says, you know, Mrs. Smith, remember how awful you were doing when things were bad, and, you know, as we added some medicines, we got you into remission, and, you know, here's what your fatigue level has done. The moment that I ever show a patient her own data, I pretty much never will have her ask, why do I have to fill this stuff out? As I used to when we just collected data at clinic visits as part of a registry where we didn't give the information back to patients. That's so critical. Again, that's that V for value of bringing value to patients with their own data. So if you have a bunch of data from patients in clinic, what about the other 360 days they're not in clinic? So I was very interested to know, what are people saying on social media? Could that be a viable data source to use? And in my world, because our drugs are so costly and companies make a gajillion dollars, there's a lot of direct-to-consumer ads. And if you ever turn on the TV, I'm sure you've seen some for psoriasis, etc. So we used a search engine to crawl all public-facing discussion boards, Facebook pages, websites, Twitter feeds, etc., most around inflammatory arthritis, mostly rheumatoid, psoriatic arthritis, etc. 60% of people are under age 40, not much of a surprise. This is where they're tweeting from. This is mostly people who don't know how to adjust their Twitter privacy settings, or they don't care. The red dots are the cities that they're tweeting from. The red shading is the states they're tweeting from. We did a word cloud to figure out what people were tweeting about. I then got the launch dates for some of the DTC ad campaigns for some of the major companies to see, are you tweeting more after a new ad comes out, and what is it exactly that you are tweeting about? My hypothesis with people coming to me in clinic freaked out about the risk for tuberculosis or things with a whole lot of syllables like histoplasmosis that don't want the drug that I then will spend 3 times as long talking to them about the safety for, that maybe DTC ads do more harm than good. So this is really intended to inform that question that I was posing to clinicians at around the same time. Do you even want to know what your patients are thinking or saying? And maybe if they're saying things on social media, do you want to know that? So I've given you a couple examples. I haven't changed the names. These are exact quotes, so these are the drug names. I'll apologize. So a med student and I went through 11,000 of these. It was doing a summer thing with me. So every time I see an ad for Xeljanz, which is one of our drugs, I can think what a great Scrabble word it would be. Somebody who probably has a little OCD who said that scores 96 points on a triple word score. But maybe quite a little bit less intended to be funny. I've been waiting 2 days for my Emerald to process, and now there's another 2 days. I could get crack faster. Some issues about access or low adherence, although maybe you're worried how they know how long it takes to get crack. The pain that burns like battery acid, is tolerability going to affect adherence? This drug, which is our T-cell co-stimulation blockade drug, has too many side effects. Folks that were worried about safety, I don't understand why skin lesions keep popping up. This is for psoriasis. Maybe those expectations aren't unrealistic. So the idea is that if, patients were tweeting all these things, here's the health theme, would their doctor want to know that? And I suspect for some of them, I would want to know those things because I could fix some of that stuff. So again, I'm trying to assemble what is here that might provide useful information that ideally you could filter out for a clinician such that they would actually want to know this stuff, that maybe you could intervene on those things. And that really, in part, leads into this registry that I co-founded called Arthritis Power. This is one of the 20 PCORI-funded registries or patient-powered research networks. So as part of PCORNet, I mentioned that there's 120 million patients with EHR data mapped to a common data model. The second data source is health plan data. Humana and HealthCore have health plan claims. And then the third is these 20 patient registries, of which I'm the co-PI of the musculoskeletal registry. People can track their health. They can enter medications. They can see how things are changing over time. There's a bunch of nested or ancillary studies so that other people who aren't me could be the PI on them, etc. We capture medication information. We grab reasons for doing things. So even if you have lots of pharmacy and EMR data, like knowing why people choose something or why they don't choose something, that's pretty important. That probably there's no better way than to ask them why they were changing, or maybe even more rare, why they're not changing if they should be. But you can ask those questions on mobile. We soft launched this, had about 2,500 people sign up, got a whole bunch of feedback. We thought about designing some surveys about what they would find useful, but in the technology world, rather than ask people what they would use, you could just build it and figure out what they do use. And that probably is a better litmus test. Rather than ask them what they think they'll do, just go deploy it or do A/B testing. We're going to show it to you one way or show it to you this other way. Which do people use more and which do they stick with? The thing they hated the most was the medication module, which I mostly personally designed. That was the thing that was hated the most, where mostly patients said, yeah, we don't want to just tell you what are the 15 rheumatology-focused medicines. We want to tell you about everything. And we want to tell you about our coenzyme Q and our biotin and our turmeric and our CBD oil, everything that, frankly, I don't really care about most of that crap. But the notion that patients want to track some of their own things that I may or may not care about, and nobody, frankly, may care about for research, but that was important to them. We use drugs, some of which are dosed weekly, like methotrexate. It wasn't enough for us to say methotrexate once a week at this dose. They said, no, we need to tell you it's on Tuesday so that when it comes Tuesday, you can remind me. Again, unless you're doing a focus on adherence to improve adherence, there's not intrinsically a research need to do that. But we went and built a whole bunch of those things simply because patient says this is important and we are much more likely to use it if you build that. So again, it's delivering value to patients for their data or to keep using an app. Back to the why will people keep doing this? Where's the stickiness going to come from? And if this is a vehicle that you're going to deploy an app so that people can give you data easily, they're going to bail on you because you've brought no value. If you pay them a lot of money, okay, fine, some will stick with you, but it might be a certain kind of person for whom whatever you're paying them is motivating and not you've made their data useful. So I think a lot more than I ever used to or thought I would about like what will people find useful, which may or may not have any research application. So what are the things that will keep people with you on a mobile technology and promote stickiness? Well, why will they keep contributing data or doing whatever it is in a digital platform or intervention? Contributive science messaging may be helpful. You're part of something. This is for the good of the community. I work with, so this registry is an affiliation with the Creaky Joints patient community. This is the altruism. You are helping science and other patients and researchers, that notion, not we're buying your data. Again, if you bring patients value to track their data and track their health, James Willig and others, have done a lot of cool stuff on campus with education and gamification with the Kaizen platform. We have an RSS feed from the patient community, even embedded in the research registry so that they can keep up on, patient-oriented research at our national meeting, for example. We're interested in sort of peer navigation within this context as well. If you can help connect people to resources like copay assistance programs, etc. So again, not intrinsic research use cases, but any of these things that help promote stickiness. And in some of our current endeavors, we're now feeding the data back into the electronic medical record with the notion that if the doctor says, Mrs. Smith, can you give me data, 8 or 10 minutes once a week or twice a month, because I think that I can take better care of you and more holistic care of you, but I need a few minutes per month, from you just so I know how you're doing. That's the notion here. This is data from a heat map from people's Fitbit devices in a project that Nada spearheaded and has done a lot of nice work with several of us in rheumatology. So every column is a patient. Every row is a person day of the study. This is a gout-focused project where, looking just at wear patterns. So this person, is solid red. Red means you're wearing almost all the day. So this is somebody who, with no extra nudges, essentially puts the Fitbit on, keeps it charged, keeps the data flowing to us. Somebody like this put it on day one, took it off, and didn't wear it for a week or more, and then was kind of erratic. And the fact that it's blue mostly means that she didn't want to sleep with a watch on, basically. And so looking at the data stream for missingness, for completeness, don't wait until the end of the study before you start looking at whether people are giving you data for a digital intervention. And Justin and others are now doing a larger scale study where we basically have a study coordinator monitoring this every couple days. Just again, because if you want real-time engagement, you need to remedy problems, as they're happening, not at the end of your 24-week trial. So just to kind of wrap things up, there's a bunch of other kinds of data. I've given you a handful of examples. The one on the bottom right, I'm particularly intrigued about, camera data. So there's an application here called Wound Selfie. The idea that if you've just had, a surgery, joint replacement, you don't know what healing looks like. What does normal granulation tissue look like? If you've never seen that before, you don't know, how warm and red and kind of angry, is this an infection? Is this normal? But you could take a picture. Or I'm interested in zoster, because that's a common side effect of some of our drugs, where our drugs double or triple the rate of herpes zoster. That's a clinical diagnosis. So in that pragmatic trial that I gave you the example for, we use the camera on the iPad to take pictures if somebody shows up with the rash, and that gets sent to the adjudication committee. People could take pictures of their psoriasis or other skin lesions. And again, you could think about machine learning or AI type algorithms. And there's some nice examples looking at melanoma or some ocular outcomes where you can basically use imaging on campus. There's a lot of biosensors available, steps, energy, distance, sleep. that's like everything can do that. But there's some interesting ones about electrodermal activity, cough and breathing, and skin impedance, etc. So you can instrument almost every part of the body, and that can be a data feed that you as the researcher can go grab. And then finally, my view of the future is really that not just research applications, but also remote monitoring for health. So the notion that, we figure out what you should do for people's health, you want to measure what you actually did do and monitor that that was happening with fidelity. You want to know what happened as the outcome. There's some new CPT codes. So in the last year, this is now a billable code that physicians or clinicians can get paid for collecting and interpreting physiologic data like your Apple Watch or your Fitbit data. This compensates $58 to go bill for this. So unlike the I only make money if I see you in person, one patient at a time at the clinic visit face-to-face, you can now bill for services, doctors, advanced practice providers, etc., for monitoring people's biosensor data for things that they wear. And so my notion is that there might be a remote care team, doesn't have to be a physician, although could be, functioning in the role of a care traffic controller that can monitor people digitally, keep them out of the emergency department, or the heart failure patient who, he steps on the ARIA Bluetooth equipped scale so that he doesn't have to call when his weight is up 5 kilos post-discharge. The ARIA scale knows that. It compares with his discharge weight when he went out of the hospital, and the advanced heart failure team calls him. All he had to do was step on that scale. Nobody had to call, nobody had to do anything. And if he wasn't stepping on that scale and weighing himself, somebody would actually call him and say, Mr. Smith, we noticed we missed your daily weight. Is everything okay? So the idea that you could be very efficient. And of course, the Internet of Things is making that a whole lot easier to monitor blood pressure and heart rhythm and sleep, etc. So that we deliver the right data to help the right care and intervention to happen. And then finally, although yes, I work in a medical center, I do actually have a sense of what the real world is like and see patients. So a couple examples where data is misused. One of my colleagues in town who was affiliated with Brookwood basically had his healthcare plan, or one of them in this city, say, Dr. So-and-so, we noticed based on your data, you're an outlier compared to your peers. You need to send all your patients with our insurance a letter. They need to find another rheumatologist. He doesn't have access to his data. He has no way to rebut that. And yet he just got rid of all of his patients because, they dropped him. So you actually want to proactively manage data as a clinician. And I think that's why a lot of people who care nothing for research are increasingly interested. And that's why a lot of physicians are forming networks to manage and control their own data, because otherwise they're seeing it used against them by health plans more and more frequently. As one of the gout projects as part of our gout court here at UAB, we had a pharmacist-directed intervention. The idea is that gout should be a super simple arthritis to take care of. You have a cheap, pretty safe drug. It costs pennies. It's allopurinol. There's a little bit of dosing with kidney disease, but adherence is an issue, and people bail on it because you don't feel better in the short term on it, and people don't refill it, and it's not dose escalated. We basically took it away from the primary care doc and said, we're going to have a pharmacist help you. The same notion like a Coumadin clinic. If you want somebody on warfarin, you don't do that your own self as an internist or even a hematologist. You send them to the Coumadin clinic. So this idea was the pharmacist is going to essentially take over and manage your gout. But in fact, she didn't do it boots on the ground in clinic. She did it across the entire southern half of the state of California at 103 offices. She was monitoring data digitally, your serum uric acid. She knew what the patient's whether they had chronic kidney disease or not. She could adjust doses. There was a care pathway. You had a part-time FTE that was responsible for 1,500 patients. So there was no brick and mortar. There's no real visits, but she had a digital data stream and a set of tech-focused tools to reach out to people. And if she needed to call them, she could, but that's not where we started. We doubled or tripled adherence and improved outcomes getting to goal therapy. So, you could make this very efficient. Some other linkages where where health plans pay different prices for drugs based upon algorithms run on health plan data. And then, a variety of interventions that have short feedback loops that I think could be facilitated with ready access to data. So with that, I'd like to thank you very much. And I guess my parting comment is, for a lot of things that are tech or data focused, you have to resist discouragement. And probably my favorite quote in this space is that most people overestimate what you can do related to technology in 1 year, but underestimate what you could do in 10 years. And a lot of, unfortunately, what I do these days is sometimes, beat my head against a wall or be creative or finesse to get permission to do something. And lots of times the will to do it and the agreement by all parties to do something takes longer than the doing of it, such that a lot of sort of, quote, technology-focused healthcare problems are not so much actually about the technology anymore. They're social and behavioral problems. Will patients do it? Will the parties agree, find enough value in it that they're interested to support this research or this care program? Will patients stick with it? They're much more social and behavioral. Connecting data pipes is necessary but not sufficient to transform healthcare. And I think this is why AI and computer science people will not take over the world. It needs folks like all of us in the room to help provide guidance and content expertise. And I think a lot of the problems, are more sociologic and behavioral as much as technology. So thank you very much, and appreciate any comments or questions.